Well, welcome everyone to this session, which is really about the importance of geographical variation. As you can see from the title, your health depends on where you live. I'm Fiona Godley, Editor-in-Chief of the BMJ, and I'm very delighted to introduce you to our main speaker and to the panel, who will be then discussing these matters with you afterwards. So first of all, just to give you an introduction to Bill Davenhall, who is going to be our main speaker today. Bill is a senior health advisor at a technology company that serves the health and human services industry as well as other industries, called ESRI. And he also has, importantly for the context of this meeting, a master's degree in including medical behavioral science from University of Kentucky, so clearly understands human behavior as well as the technology aspect of it. To talk and respond to what Bill has to say, we have a wonderfully international panel for us today. So starting off just next to Bill, we have Stefan Beiersdorf from Germany, who's a consultant at McKinsey's. We have Nora Al-Nawaisa from Saudi Arabia. We have Jean-Luc Aousseau, who is the president of the Haute Autorité de Santé in France. And we have Colleen Kivlanon from the AAMC, the American Association of Medical Colleges in America. So let me now, first off, hand you over to Bill Davenhall, who's going to tell us why your health depends on where you live. Thank you, Bill.
Thank you, Fiona. Well, good afternoon. The toughest role of a speaker is right after lunch. Most of you know, being in medicine, that you probably, in healthcare, that you're biochemically low right after a big meal. So my job is to keep you awake, and I hopefully will do that. The first slide I would like you just to read, and I'll give you a few, maybe 30 seconds to look it over. I may have some conflicts of interest, but I don't think I do. Many of you probably use our technology in some way in your roles, and you'll be a customer. But for those who are not, here's my statement of my conflicts. So what we're going to talk about here today is know your place. And what it has to do is the relationship between your personal health and what we call public health. And there's a lot of anxiety around the world about this topic called population health and its relationship to the human genome. And while it's not all sorted out at the moment, I'm here to tell you that there's a tsunami of data headed your way that will be highly geographically specific, it will be continuous, and it will never stop. Of course, unless you choose to shut off your cell phone, which most people choose not to do. So this is a story. I'm going to try to really relay this story in such a way that I get you personally involved in this presentation. First of all, I'd like to say I always have hopes for my audience as I give this presentation. The first one is that you'll reconsider your thinking about your relationship of the environment to your own personal health. The second one is that you will use all the data that's available to you and is relevant. We waste so much data today that this is going to be a problem of the future. And the last thing I'd like to ask you to do is really try to internalize this presentation today in your own life and the life of your families. Because I do believe your place history will have a profound effect on your lifelong health and well-being. I started my life in a place called Scranton, Pennsylvania, a northeastern part of Pennsylvania that was a coal mining region. And in the process of digging coal out of mines, they created these huge mountains of what were called cold slag. And after a few years and decades, these things caught on fire. They were huge. They were mountains. And they smoldered for almost 30 years. Now, other communities that have, in other parts of the world, that mine coal have similar kinds of problems. But for the first 19 years of my life, I breathed this air. This is what filled my lungs every day, and for the people who lived in my community. I then grew up and decided I would go away to college, and I went to Kentucky, and I ended up for 25 years in a community that manufactured polyvinyl chloride. Now, no one warned me that this might not be a great community to live in, that I'd have to breathe the air. But anyway, that didn't seem to bother me. Nobody warned me. So I went there, and it was beautiful blue skies, and these factories didn't seem to be that obnoxious. There was a little odor in the air. But of course, if you followed that from a medical perspective, you discovered there's a lot of brain cancers that come out of communities with polyvinyl chloride. And then to make matters worse, I decided to go work for this company that I'm the senior advisor for now in the LA area. And I was introduced to a sunset that looks like this. It looks really beautiful, but it's really bad air. In fact, it's probably the worst air on certain days in the United States. So I spent another 18 years breathing this particular air. Now, to say that I had some risks ahead would be an understatement. In my own personal life, I was speeding to a future that I had no understanding of. Now, many of you can relate to these things because you too have your own train wrecks. Personally, you have them in your families. You have cousins and aunts and uncles and mothers and fathers and grandfathers who have told you stories that sort of sound like, I think there was something in our environment that had something to do with this cancer, this particular diagnosis, this particular death. And I like to call these train wrecks because that's what happened to me after I was diagnosed with something called exercise-induced asthma. Right? Very interesting term there. My physician at first said, well, Bill, you get this because you go out running and you run after work. And he says you should run in the morning instead of the afternoon. Well, that was a new piece of information. But anyway, I had this pretty good heart attack. And while I was recuperating, I had all these kinds of questions starting to float to my mind. Like, so, Bill, you're a pretty smart guy. You've been in the health field all your life. How come this took you by surprise? How come this freight train bore down on you and knocked you off your tracks? How did it happen? Why did it happen? Why was it here? Was it accumulating? No doctor had ever warned me that this train was right behind me. And now I was even worse. Like I said, well, what do I do next? So the first thing I did is I started to do a little homework. And I found, of course, the seminal work of Jack Wemberg from the Dartmouth Healthcare Atlas, who happened to produce this map and said, here's where people have acute myocardial infarction. And so the brightest red on this map is where if you wanted to have a heart attack, these are the places you would go to live. Sort of like the takeoff of our young fella in the first slide. Let's turn this around a little bit. If you wanted to have a heart attack and pay attention to your health, you would head for the red areas. Well, two are really red, and then I moved to LA, and that's sort of red. But you get my understand, maybe you can understand here that this isn't a random event. And that I had a choice I could have made if I had this kind of information. And certainly if my physicians in Scranton or Louisville had had access to a map like this, and I told them that I was moving to Los Angeles, they might have a second or a third opinion on that. So that led me down this track of saying, okay, so what determines my health? Now, many of you got this in your health training, and it's called determinants of health. But the first one we're going to pick on is genetics. And there's all sorts of arguments about how important genetics is or is not to our human health. But I'm not here to debate that. What I'm saying is it's one of the many factors and one of the many data pieces that's going to start to flow into our medical records, and our medical community is going to have to start explaining these things to us. Now, the other thing I learned is how we live. So it's called lifestyle. Now, I actually don't have any clothes that look like that. But you get the idea that what we fill our bodies up with and the way we choose to use our spare time have a lot to do with our long-term healthfulness. And then, of course, I also learned from this very community over the years that going to a healthcare provider itself can be a hazard to your health. That there's a lot of things that occur in these environments that are not patient-centric in a positive way, but very negative. I read last week where Medicare has said that $20 billion a year is spent treating septicemia in American hospitals. Well, that tells you that the hospital itself isn't actually a healthful environment and may have bad outcomes for your health. So this is what it boils down to. We all have these personal environments. Now, we have more than one environment. You have the environment where you spend most of the time sleeping. You have the environment of where you go to work. You have the environment, perhaps, of the places you play on days off and weekends and holidays. And that's multiplied many times over a lifetime. So, how many have moved more than 5 times in your life? Raise your hand. Yeah. How many have moved more than 10? Yeah. How many more than 20? Get to the clinic. The point I'm trying to make is that why is the place where you lived not in your medical record? And I don't mean where you live today or where you work today, but the entire history. These are where we actually begin to measure the qualities of our environments. We have this thing called personal lifestyle. You know, what we eat, what we drink, whether we exercise or not, these are all determinants. They're loosely measured in many ways. We sometimes measure them after they have done their damage, and then we focus and concentrate on them. And then we have this whole area of personal genetics, where we not only have our genome, we also have a map of those genomes that can start to relate one set of your chromosomes to others, and I'm talking about both geographically and familially. And then you have your disease carrier status, where it can be known whether you're actually going to maybe skip a generation and pass it on to your children or your grandchildren. All this kind of data now is starting to build up what are called geospatial attributes. Where did this actually take place? Where are you specifically from, and where have you been? So here's something to look at. Now, this is what I would call, this is population health. Right? So I would ask you to quickly pick out all the households that have blue tarps. So have you done that? So we're going to move from what I call population health, in which we're concerned about a whole community, and now we only want to concentrate on those places that have blue tarps. Well, you begin to see, if you just magnify and enlarge this kind of data, that the ability to do this quickly and expertly and know where to target your interventions, it becomes critical that people start to understand the value of geography in their lives. Most of the data that we need to do our analysis, we claim we don't have. My argument is we have that data, and we have loads of it. What our problem is the analysis is complex and deep, and it's under a lot of water. One of the more recent analogies here, of course, is the pingers on the Malaysian airline. It's like, so what is the new problem here? Is it a data problem? Is it a policy problem? And you begin to realize that if it took 3 weeks to triangulate and do the mathematics to figure out where this plane might be, what are we going to do when we get to medicine and have the complexities of all the genetics, the lifestyles, and our place histories? It gets complex very quickly. So I'm going to show you only a handful of maps here today, because the point is that there's 10,000 of these. There's hundreds, thousands of these. And I would say most national health authorities spend a lot of time and effort producing data that ends up looking like this, that essentially distinguishes the fact that these are not random events. They can be highly localized. So here you see ozone in Europe, and you begin to see that if you had some sort of ailment, that ozone triggered a negative aspect of that exposure, there's places you might choose not to live. You might be all right to visit, but maybe you wouldn't want to live there. Here in the United States, you see diabetes. Now, this pattern, if you looked at probably 100 diseases, replicates itself over and over again. So we suddenly realize that there's clustering going on. And the beauty of beginning to pay attention to geography is it helps sort out the priorities. So if you're going to study diabetes, and really get at the root of the problem, you probably could guess by looking at this particular map, and this happens to be incidence, that you would decide to go to certain places and not others. Here's another one. This is what would you call it in Europe? I think it's called it's like a mite. It's like a tick. So, responsible for Lyme disease. And you begin to see that if you knew exactly where that data came from, and you knew exactly where you've been and where you've lived, you could start to put those two pieces of data together. And it would give somebody a clue. It would give either your physicians a clue or it would give you a clue. So suppose you were a vacationer and you came back and you had these idiopathic symptoms that a doctor far away couldn't explain, and you said, well, this is where I was for my vacation for a month, and it happened to be in one of those dark red areas. Well, what you might do is save a lot of time, because now we had some data that would get us into the right thinking. Here's pesticide runoff. So it's just not about health anymore. There's data like this almost on every human activity that you can imagine. So here's one where they actually measure where pesticides run off a farm field and find their way to waterways. Well, can you find your house there? Would it be nice to be able to drill down and find out that you lived in one of those purple regions? And it may or may not have anything to do with your health. But there's a good chance if you have some issue, a reproductive issue, endocrinology issue, that this might be important information for both you and your physician to begin to work with. Here's a recent piece of information from the Dartmouth Atlas that dealt with prescriptions that are still being prescribed by physicians, billing Medicare. This is a list of about 100 medications that have been, a panel of physicians that concluded they should no longer be prescribed to seniors. So I admit I am a senior, so this was particularly of particular interest to me. And I said, well, this is kind of interesting. You mean all those dark places, we still have physicians that haven't got the memo that these are harmful drugs to give seniors. Now again, where do you live? And is it possible you might choose to live in a place where from the very beginning it would be safer from the medical treatment aspect, that you wouldn't have a physician writing a prescription that's likely to harm you? So how does this all work? Well, it works because everything we now sort of work with is in layers. All the data that's now coming to and from your cell phones are all in layers. And so, you can, there's apps that you can see all the attractions that are around this building. That's a layer of information. The utility companies of Paris use this technology to find where all the wires and cables are. The water people find their water pipes. And if you can imagine almost any human activity, and particularly if it had an engineering aspect to it, has very, very detailed specifically geographical in nature of where these things exist. And about the only thing that isn't nailed down at this moment is this person called a human running around thinking that place doesn't matter, when in fact it very well might. So you can begin to think, and I'd like you to think about in terms of what you do, what is the layer of information that you're the custodian over? And is it useful in the grand ecosystem of health and wellness? So we're moving from this environment of which, okay, this is great. We have population health. We know a lot about our communities in general. But when we go to a physician, there is very little evidence that that physician is really engaging with what I call population health information, to the extent that it's going to be useful in that exchange. So my example is if you're a physician on the west coast of a country and you see a patient from the east coast and say they're 40 years old and there was some environmental problem that happened on the east coast, what are the chances that the physician is going to think about that right off the bat? Or that you as a patient, what if you were a teenager and it was one of those years where you don't pay attention to anything? You had no idea that that was occurring either. But those two artifacts exist in fact, and they're just not present inside that medical office where there's a diagnostic or a therapeutic or even a discussion in general nature about what might have brought these symptoms on. So getting from the communities and that overview of population health to what's going to transpire inside that doctor's office is not an easy step. It's complicated by the nature of the workflows. How many people have filled out more than one personal health inventory for the same physician's office? Do you know what a personal health inventory is? You know, that's the one where you give up your social history, your surgical history, your pharmacology history. What other kind of history? Genetic history, maybe? Family history? I mean, you get it. And I would challenge anybody to come up afterwards, and I will give you a 20 euros if you can prove to me that your physician collected all the places you ever lived. And I'm sure I'll be able to keep that 20 euros. The point I'm trying to make is that if you believe that the environment and the place where you live is important to your health, then I would say to you, why isn't that reflected in the great valuable data histories that we're creating all over the world with this thing called electronic health records? The United States just spent $38 billion. Say that again, $38 billion. And there's not a place history. There's room for that place history, but there's no place history that's in it. And I would say to you that in the future, our children and our grandchildren are going to expect much more out of our information systems and our, what I call our voluntarily providing this kind of information to providers. They're going to expect providers to use it. So about 2009, I created a term to better describe what I'm calling this, and I call it Geomedicine. And really what I'm doing is stapling together the knowledge of public health that's enormous with what I call the very almost tactical needs of a healthcare provider and a patient. You know, a lot of people are into ranking hospitals and ranking physicians, but I know as a patient that when I'm really sick, I don't go shopping. I typically go buying. And I have very little time, talent, or interest in trying to study the books, the internet sites of who's the best doctor. I want to get well and I want to get fixed. So sometimes when we talk about evaluating quality, it's an armchair kind of activity that people do when they're well, or if you have a family member that's so concerned because you can't do it that they take on that role. So the realization is this has to get easier to do. And instead of giving me a website that has 100 hospitals in my community that could potentially treat me and their qualities, why don't I have a site that just tells me where I need to go? I mean, you know, the data would tell you where is the best place to go. You think about it, right? So this is what people are going to want. They're not going to want to go through this fishing expedition in terms of what I call the difference between shopping and buying. So this geomedicine thing is about these two train tracks that are going down side by side. One's public health, and it's got a public health doctor. And that doctor went to a medical school and then got some advanced training in public health. And then the other doctor on the other side of the car, you know, didn't do public health. And they're both looking out their windows. One sees a valley, you know, and cows grazing. The other one sees mountains and cliffs and streams. And the patient is in the middle here. And by the time you get to this intersection, what's going to happen? It's very possible that there's no interaction that occurs. They made the same journey. They went to A to B, but they know less about you and your context of your life in terms of its health and wellness than when they first got on the train. Now, there's no shortage. This is sort of like I'm trying to prove to you that you know this is true. There is no shortage of information about the toxic effect of our environment on health. These are headlines I collect as I go around the world. There's no country I've ever been in that I'm disappointed. There always is in the newspaper, a local newspaper, some story about something like this. You know, China with their lead, pollution over uranium. I lived in a community and we drank rocket fuel. old junk vehicles. You see okay, so each one of these stories is geographically specific. So how do we capture this information and make it useful to someone who might be looking at my medical problem who had nothing more than the proximity? They knew I was in close proximity to something like this. Would it be useful or not? My argument is I think it would be. In the United States, as there are in many countries of the world, there's environmental protection agencies who actually collect very geographically specific data on where all the toxic material is buried or stored or spilled. In the United States, we have a database that goes back to 1987 that's been routinely collected. Site-specific, latitude and longitude, as precise as your cell phone will give you a location. And here's the results of all those years of where they've dumped toxic waste. I only looked at the ones that were, in the next couple slides, that were carcinogenic to humans. Talk about 60 million tons, and you can see it affected 27% of our cities, 33% of our postal codes, and 50% of our counties. The problem is, you don't know where those are. My physicians don't know where those are. That's the problem we're trying to get under here. So you have to become a student of what I call the Dartmouth Healthcare Atlas, and I would say anybody who is motivated and interested in following what I'm saying here today needs to head to the Dartmouth Healthcare Atlas and begin to understand this whole area of study called geographic variability, which, by the way, is going on in about 40 countries across the world, where senior healthcare researchers, usually associated with a medical school or a medical institute, is beginning to take a look at data in this kind of way and basically producing maps that say, this isn't a random event. Now, it's either going to help us in our diagnosis, it could help us in our treatment, and it certainly could help us in clinical trials to know where to put the trial, where actually it might actually prove to us that it's beneficial to the population we hope the drug will serve. So it was Dr. Wenberg who said geography is medical destiny. And when he said that, I remember everybody sort of couldn't understand that. They struggled with what he was really talking about there. What he was saying is the unit of analysis became the geography. And by looking at geography, you could begin to see these variabilities that were very obvious. So here's one. Here's those top 100 carcinogenic chemicals collected since 1987. And those are the 100 largest places in the United States. Now, if you're familiar with the United States, you may know generally where those are. But let's add something else. Let's add some other geography. Let's add waterways, streams, major rivers and streams. What do you see? You begin to see that some of these enormous toxic reservoirs are located next to rivers and waterways. And then what if we added a layer that the people that are in the geology business collect, and their layer of data is aquifers. These are the great reservoirs under our earth that store most of our drinking water that we pump out and drink. So now you can begin to see how this looks when you take some of this carcinogenic material and put it over an aquifer. So these are the kinds of things that I want you to begin to think about in terms of layering this data in such a way that you start to build what I call understanding of what's happening here. This is what, when we talk about context, this is what we're talking about. So one of the things to think about building is this new machine. Now, has everybody seen this machine before? Have you had your head into it? You know, this is the one where after about 5 minutes you want to get out of it. The ophthalmologist or the optician keeps saying, is this better or is this better? Is this better or is this better? And you know, after about 10 minutes of that, you don't know what's better. You know, you think you know what's better. And you actually say, well, maybe I don't even need glasses. But what this is about, this is the kind of energy that's going to have to go in to improve the quality of the data and allow people to make decisions about patient safety. I'm always amused. I worked in a hospital for many years, and I was always amused by, when you leave a hospital, you can't walk out on your own. I've never been in many of them that allow that. They put you in a wheelchair, and some attendant takes you to the parking lot or to the front door. And then we sort of dump the patient into the car or the vehicle, tell them to put on their seatbelt, and wave goodbye and good luck, and then step back. And I've often been, it's not that it's humorous, but it's sort of like misplaced precision. We just had this patient inside our walls. We had all these, clinics and in-services to make everything go perfect inside this institution. And then all of a sudden we turn this patient loose, as if our responsibility stopped when we put them in the car, that our liabilities stopped. And I would ask you that as you think about patient quality and safety, and I know you do think about this, has to extend way beyond that wall. And we're now talking in the United States about how hospitals are going to have to go into people's homes and actually inspect the rugs on the floor so that some senior who's just had a hip repair doesn't trip over a rug and is back into the hospital within 30 days. So it's going to require a much higher level of precision in our work to take care of the quality of the data so that we actually can live up to this, what I call wall-to-wall patient safety issue. So my contention is that where you live and knowing your street address becomes critically important. In fact, I believe it's going to be the seventh vital sign that we have in medicine. That this thing called place or your street address is a surrogate, a proxy, if you will, of the context of your life. It's not only going to tell you what everybody died from in your neighborhood or what the quality of the water is, it's also going to tell you what's the quality of the resources that are available to you to help you with your healing or your wellness. It's going to tell you what kinds of stores and food places might have the right kinds of foods for the special diets that you have. And you can begin to see that it's just not a thing for detecting disease and tracking disease, but it's also one of actually helping and assisting in interventions and in the whole patient treatment, wellness for a life. Now, I invented this after the first year of talking about geomedicine because people were struggling to really figure out what this could do for them. So we created an educational tool. It is free and it's available on the internet. You can download it from the Apple Store. And it's called My Place History. Now, it was not intended to be, I wasn't out to build this application for the world. All I wanted to do was to demonstrate how now technology allows us to take two what may be seemingly disparate pieces of data that are only related by their physical proximity and put together easily so that a consumer would be curious enough to go to this site and take a look. So this application will allow you to put an address in for the United States. So if you have friends and families that are in the United States, you could use this. But most countries have the capabilities to do this address relationship finding on the internet and also tie it to databases like this EPA database. So you can see that what this is going to end up doing for you when you put it in, it's going to give you a report, and it's basically going to tell you how close you lived to some of these chemicals, and it's going to tell you what the chemical was, and it's going to tell you the name of the company and the address that company is located at. And so, some of you will be fortunate if you live in the United States. You won't be close to anybody in 3 miles, but there's others that are going to be very close. So it was an attempt to begin to get people to be curious about the environment that they're in. What they actually do about that is sort of unknown at the moment. I set this up so they could send an email to their physician. That really made a lot of physicians happy. I was joking. They said, we don't need another research project in this office. But we have found that they go home and look at it for their own families. So the idea is how can we use technology in a much smarter way where we're going to be having all this rich geographical data coming into us and use it in such a way that we engage the patient in this process so that now when I do this, I can say to my physician, I live in a place that had, I might have some problems here, and here's why. So the two things I called for in 2009 was, let's do two things. Let's start to think about how we're going to do two things. How are we going to train medical students in this whole new piece of technology that I would say very few physicians even heard about in their education? How are they going to learn how to use this particular geographical information? So there needs to be some training. So I said, let's see if we can find a way to put some curriculum into medical schools so that people begin to understand the value of this kind of data and how they can incorporate public health information in a much smarter way into their clinical practice. The second thing was, let's go to work on the electronic health records and begin to figure out how we can put this kind of information into a medical record. Now, you don't need to put all the information. All you need to do is to put the latitude and longitude into that, because there's other ways you can connect that with both your own clinical data repositories and all the third-party data that's outside of your organizations. So here's where we're headed. So I say we're in the era now of citizen epi, right? Everyone's going to be their own epidemiologist. So I'm sorry for the epis in the room. You don't have a whole lot of job security left. That we who integrate and work with our own personal technologies are going to have as much information, if not more, than you do. And there are tools and techniques on the internet now that make it possible for a community organization to declare a cancer cluster outside of the health authority and outside of Centers for Disease Control. And you say, Bill, that's crazy. I never heard of that. Well, just stay tuned. And there are stories I could tell you about communities who have done their own epi work to prove to health departments that it was worthy of their time and energy to study that. So we all are going to take a much more active role in maintaining our data. Now you see a picture here of, how seniors are going to spend their time in the doctor's office. On average in the United States, a senior will spend 11 minutes waiting to see the doctor. So for those that are math majors, multiply 11 minutes times the 1 billion visits that were made last year, and you can then figure out how many centuries we spend sitting reading stale magazines in doctors' offices. How much better could we use a patient's time if we had them engage in a process where they either gave us additional information that would be considered added value, or give them reference material that can begin to show them that what's happening in their neighborhoods is either good or bad, and start to educate the health-seeking consumer. So this is what I think my future is going to be about. It's going to be talking about what I call place informatics. Now, people tell me when I use the word informatics, only the academicians understand what I'm talking about. They said it's very academic, don't use that term, Bill. But I do think it has important meaning in the health field, and that is, this is going to be a specialty in medicine where students, medical students, will get degrees in understanding the context. I know I've seen a lot of publications lately about the importance of context. Well, I'm expanding that context. I said there's a clinical context, and then there's a non-clinical, and it's all that non-clinical that really has a lot more to do with what we do when we go home than anything that happened in the clinical world. Right? So whether we have access to the things we need, whether we're capable to follow through, and so forth. So this is what's going to look like. Now, these are real. So I just took the data I had, and so where I live in Phoenix, Arizona. That's the state that holds the Grand Canyon. Now, at the top left, you see that I discovered by using other people's data that came out of medicine that I have harmful senior prescription use. So, I'm not doing too good in there. There's a good chance my physician is going to give me one of those prescriptions that's on the banned list. I also found out that after an AMI, we have very low senior statin use. That's bad. That's against the clinical guidelines. But I happen to be in a region and in a neighborhood where that's likely going to occur. I have high prescription costs, and I have very low primary care access. So the smiley face is not a smiley face there for me. Now I go down to the cancers, and I find out I'm okay on the cancer rates, seem to be pretty good. We tend to live in a place where we all like the brand prescriptions, so we're spending more money on that. And we also have pretty good toxic chemical releases in our area. So that tells me another clue. But the good news is I live in a place that's very walkable, and it has a very high walkability score. And I also have a high score in patient treatment preference. Now, according to Dartmouth, this means that if I have a terminal illness and I choose not to die in a hospital, I can make that decision, and I'll be encouraged and actually given that preference by my physician. Now, on the other side there, I also did a 23andMe genetics report, and I found out that I have above average risk for heart attack, 10% above the average. And you can go down the list and see what else. Now, I've already had the heart attack. I've had the AFib, and I've had the exfoliation glaucoma. So I've done pretty good, right? I mean, I've hit 3 of those. The only problem was I didn't know it until like 2 years ago. Right? Now, the question I have in my mind was, had my physicians had this kind of information? If I had had this kind of information, what would I have done with it? And the point I'm trying to make is, I would say most of us probably would kick something into action and say, well, I need to think about doing something different, and if it means moving, I may have to move. If it means getting my health authority to pay attention to this particular problem, maybe that's what I need to do. The point I'm trying to make here is this is the kind of information that our children and grandchildren are going to be getting. They're getting it now. We're getting it now. We have it accessible to now. The problem is there's no framework within which we now can push this information that makes it really useful for a physician. If I were a physician, I don't want another research project unless I'm a research physician, and I haven't got time to do that if I'm out in private practice, out on the frontier. So the point I'm trying to make is this information is coming. We're not going to be able to stop it. The only thing we're going to be able to do is to begin to think differently about how we're going to consume it and use it, and work with our health-seeking consumers. So probably the most important thing that a parent is going to say to their children before going off to school is don't forget your phone. They're not going to say, be sure to brush your teeth, make sure your shoes are tied. It's going to be don't forget to take your phone, because that phone now, you're going to see phones in the next year. They're going to have probably upwards to 15 different biometric devices incorporated in them. You'll be able to blow into the microphone and get a DUI. You can get a breath analyzer, alcohol analyzer. It will measure ambient air quality. So you're going to see a whole host of things now that are going to get tied to the technology that are going to push this flow of data farther and wider than you've ever seen before. So the struggle, I think, between public health and private health is how we're going to bring all this information into a much sharper focus so that a partnership actually forms between a patient and a physician or a caregiver. That they have as much information as they need to have to give the highest quality of care that they know how to give, and at the same time not be burdened by paper and time, because these are the things they don't want and don't really have excess amounts to. So for those that are familiar, what I'm trying to do is say we have to develop the equivalent of a SMAC 24 report, something that a physician can look at and say, okay, I'm going to go down this road because all the data suggests that this might be what I'm really looking for. It's not a substitute for their education or their journey or their residency or their internship or their judgment. It's an additional piece of information that you would rather have than not have. So another place you can go to learn more about this is you can go to this page, and it basically will show you a 8-minute video that talks about my own personal story of this journey. It will give you access to this place history, and there's an e-book that you can download that will tell you more, as I said, if you're interested. That's what this e-book looks like: Geomedicine, Geography, and Personal Health. I want to conclude by saying, there isn't one fork in the road. I used to think there was, but I've learned now there's not. There's many forks in the road. And our challenge in the health and human service space is, number one, what forks do we pick up? We're going to get a choice here. because, first of all, we can't pick all of them up. And first of all, you've got to pick them up fairly quickly, otherwise you're going to get run over. And so that we got to be very careful of what we spend our time studying. So if I tell you that chronic disease is what's going to take down our ship, what does this mean for acute care, where I've spent most of my life? It's going to require us to shift our resources, shift our education, shift all our strategies and our interventions. We have to go to the place where the most people are going to be impacted and most of our dollars have to be spent. So at the end of the day, we are either jumpers or catchers. And in some cases, we might be both. But you know, if you think about this and look at this picture, you realize what's really happening here. It's called trust. You only have one chance there, don't you? If that catcher steps aside, what happens to the jumper? And what does the jumper do from that day forward? Right? So you begin to realize that what we're dealing with here is the responsibility to use all the data that's relevant and make it it might be a challenge, but make it a priority in our life, and then understand how to use it more effectively, so that when we end our day, we feel that we have created a trustworthy environment or a trustworthy ecosystem. While I could tell you I have great care from some of my physicians and some of my hospitals, they're not connected. There's not much integration. There's not a lot of service coordination. And the only person that truly knows the extent of my health and wellness is myself. And I think what you're going to see is this realization that that's probably going to be true for most of us, and we're going to have to get much more engaged, and we're going to rely on our healthcare ecosystem to support us, like was said earlier this morning. And, flipping this, making it so that the physician becomes our coach and begins to work with us in this regard. I want to thank you very much for your very kind attention. And Fiona, if you'll kick off the panel and their questions, appreciate it. Thank you.
Thanks, Bill. Bill, come and have a seat. Thank you very much indeed, Bill. Wow, it's a lot to absorb. I don't know who wants to kick off with the responses. Stefan, let me turn to you first. What did you take from that?
So, Bill, thanks a lot for this truly inspiring presentation. And I must say, I'm personally a big believer in the power of data in healthcare and in medicine. So there's one question, though, that comes to my mind. And you mentioned that in your presentation as well. There's a lot of data available. Data about medication that shouldn't be given to elderly. Data about guideline violation of patients with chronic conditions, or even the information which hospital produces better outcomes for certain type of procedures. If you compare this wealth of data now to this new type of data, the geomedicine, wouldn't it be an easier step to do first in analyzing this data, which is there about guideline violation, medication errors, and so on?
Well, all that data presently exists, and it's in silos. And you have to almost know what you're looking for before you can find it. So if you're in the industry, you probably have a good idea where to go to look. Now, I would tell you, I saw a lot of interesting billboards here in Paris on health intervention programs. And most communities that I visit would have that, right? I didn't see anything that directed me to a website, for example, that was going to help me learn about all that, which we just talked about. So part of this is going to have to be a maturation that occurs in the people that have the resources who are actually in the business of promoting health and wellness. They're going to have to view their data differently. They're going to have to flip this data and say, I have to push more and more data out there, and then stand back and sort of coach it. First of all, coach it in terms of is this of interest to people? And if it is interest to people, then how do I get them to look at it and engage with it? So the what I would call the integration of the data is a huge piece. And I would say you're going to find a lot of people in the big data excitement of the day, realize that it's the devil's in the details, as we would say. How do you relate all this information together in a useful way that makes it geographically specific and relevant enough that you care to even engage with it, or that your physician would engage with it?
Thanks very much, Stefan. I'm going to stand up so I can also encourage the audience to feel that you might come up to the microphone at any point if you want to bring a question forward. Nora, your responses to what you've heard from Bill.
Yes, thank you, Bill, for an interesting presentation. I have a bit of gray area about regarding the geomedicine as an introduced concept versus epidemiology and public health, and you have nicely presented that you have to take this information. This is my first gray area. And the second, okay, it is important, and as a family physician I always ask my patient about history and environment and everything, but how much really in scientific evidence this data will help me to project, like in 20 years you lived in a place, really, is that place really have affected or caused the risk which you are suffering from? And if you have such a data collected, or are you looking into it?
So, you know, my answer to that question is typically, my role is to get the right people working on the right problem. So the problem I'm trying to solve is what I call the proximity of data association. And in research, you know, that's actually, they help set up the indicators,
yes,
but it's not cause and effect. So there is a big leap there that occurs, but that shouldn't prohibit this commingling of data in such a way that they share something in common. I like to tell people that this thing I call geography is the lowest common denominator. So if I have a latitude and longitude and I can describe all that goes around it and is on it and in it, okay, then what I've done is I've put that all together. I've co-located it. But it doesn't mean that there was a cause and effect. But I say at that point, that's where the research community has to kick in. I can't tell you how many clinical trials I look at, and I get to look at a lot of them. I serve on a couple different boards in that area, and they, a lot of drugs, the big blockbuster drugs they talk about, they actually have been more successful in the off-book use of that drug than the on-book. And what happens is they go back to the same places for their clinical trials over and over and over again. Okay, so you begin to realize that if we had smarter information, we would begin to think about how we're actually picking those sampling frames for clinical trials, so that we actually got into populations. It's like the asthma drugs. You know, they exclude most people that have asthma from all the clinical trials in the asthma drugs. I don't really understand all the background of that from a scientific point of view, right? But these are the people that actually need the treatment and are going to create the the tremendous cost waves for us in chronic disease.
Bill, let me bring in, I think, Joanne. Just introduce yourself, Joanne, and give your question.
Joanne Conroy from the AAMC in Washington. So just a couple quick questions. Number one, I expect you're talking about the social determinants of health, but you're really expanding it. So it's much more than what we traditionally think of are additional determinants of health. You're adding location and everything else that's not necessarily related to the economic indicators, but will be important to health, number one. And number two, can you talk about the role of analysts like the author of Freakonomics that made some really interesting observations that I don't think the average person can probably make? Given all this data, we almost need somebody to filter it for us to determine what's causal and what's correlated in terms of some of these variables. So I'd be interested in your thoughts.
Thank you. Bill.
It's a great question. Most of the framework that I'm looking at in terms of geomedicine is probably better if I use the term geohealth, right? So it's much bigger than just medicine. So it's saying that, so what does it mean? What does wellness mean? And if you go to the WHO definition, you find out it's just not the absence of disease, right? So it's about how you build a framework for analysis that says we have to figure out how we're going to put genetics into the formula, how we're going to put environment into the formula, how we're going to put lifestyle into the formula, and what percentages and what weights we're going to give to that, and how much can we know about the communities from which these patients come from, or health-seeking consumers. So part of this is that challenge of what I call the analytical framework itself. And in some ways, what I'm arguing for is, at the same time, the bathtub is going to get full of data. And there's only a certain size drain at the bottom. And that's where this selective process that you were talking about comes in. So can you take every piece of data, and is every piece of data relevant? So this is what the whole question of big data and what I like to call little analytics is about, is that we're going to have to figure out how to take this data and winnow it down so that we end up with a core set of data that, I mean, most communities have 250 national indicators of health and wellness. And I know very few people that can handle 250 variables in their head and figure out what to do. So part of the call from the public on this is we can't be spending all our money trying to solve all the problems. So at some point we need that kind of analytical filter, if you will, to sort of make some decisions. What is the most important health problem in Paris today? I don't expect an answer there, but somebody probably knows.
I'll tell you who may know. Jean-Luc, that's your cue.
What is the most important problem?
Well, that was one of my comments. Depends on the place where you live. But for instance, if you live in this part of Paris, your life expectancy is very long. If you live 5 kilometers north in the suburbs, you have a short life expectancy. But it's not due to geography. It's due to socio-economic situation. You have rich people here, you have poor people in the north. So that was one of my comments regarding the influence of geography on public health. It's not only geography and environment, it's also socio-economic in a given region.
Right.
Before you answer that, Bill, let me bring in Colleen and then we'll get back to you. Colleen, your thoughts.
So, Bill, what I heard you describe is the importance of context. In individual health and in population health, I heard you describe the need for a framework that integrates medical and public health data into a single set of data. I hear all of us asking for what are the key predictive factors, so that we can actually use those, and impactable factors, let alone predictive. And the question I ask is about your app, actually. So when we think about who uses your My Place History app, what we know from the personal health records that you described is that very few people voluntarily do that. Google Vault and others have closed down their personal health records because so few people actually completed them. There are very few countries who have a standardized set of socio-demographic and environmental variables that they collect. So who's likely to use those apps now and in the future? And what is it about the selection of those people and the data that might result from those data collection devices? So any thoughts on that?
Right. Well, not to be too simplistic, but I'd say what I'm trying to do is to create the same sort of emotion of why we all go to Google Earth and look at our rooftop. I don't know why any of us do that. We know where we live. So I have no idea why we do that. There's an element of curiosity here. And once you begin doing that, then you begin to want other kinds of information to come into play. So who uses this information? I would say Jean-Luc there was talking about where the framework is geography. It's not necessarily a cause and effect. It's not like we're saying that the geography you live in is causing your bad health. We're talking about what happens in the geography of where you live that's causing your bad health. So if you have physicians that are prescribing these banned medications, okay, I would say, well, the first thing that jumped out to me when I saw that map is, well, there's a project for somebody to get an educational program in gear and go into all those bright areas and try to inform physicians about what's happening here. You could do it two ways. You could inform the public and you can inform the physicians. So in some ways, it's going to be the consumer that's using a piece of this information to contribute to the process. If you're not moving anywhere, I've had a lot of people say, well, I've never moved in my life. I've been in the same place all my life. Well, that's very true, but the data tells us something different, that we're all becoming more mobile. We're moving off the farms and into the cities. We're becoming more urbanized. So these differences that you're talking about, even in Paris, get exaggerated in certain ways. I mean, in a positive way, exaggerated from the standpoint that epidemiologists can identify more precisely exactly where those clustering. We have these techniques now that we see on our cell phones for weather data. They're called clustering and hot spots. And so I would say the user now is getting mixed up. It's like it's like the citizen epi person. So you have health-seeking consumers that use that data to see whether, in fact, they should move to St. Charles, Missouri, right?
Bill, can I just
give them a clue.
Sorry to interrupt. I've got some comments from Twitter here, thanks to Emma down there. So people in the audience have asked a number of questions which relate to what you've just been saying. So Sophie says, do the maps of health correlate with maps of deprivation and encouraging those who can afford to move? So the idea is that actually it becomes another incentive of sort of what in some places is kind of white flight or middle class, evacuation of rougher areas. Then Susan says, is the premise really to identify geographic areas of risk so patients can move? How about we tackle social determinants of health and create better health for all, so that instead of movement, people, it would be a way of identifying the issues. Toby says, great that we can use geomedicine as part of risk assessment, but could this lead to overtreatment based on fear? Or will impact of geomedicine risk appreciation detract more from modifiable risks like inactivity? That's rather interesting. Maybe I should read that again. Did you understand that? So maybe there are modifiable risks that we should be focusing on in those areas rather than overtreatment based on fear. And then the final one I've got here is from Deirdre, who says, research focuses on cities because of economies of scale. How do we convince finance people to focus on rural areas? So I don't know, I'm going to go back around the panel and invite you each to comment on some of those things or anything else that occurs to you from this conversation. Colleen, over to you.
I think it gets to the predictable and impactable or modifiable risk factors, right? So how do we tune into the signal and not the noise? So I think that's a real risk. And that is without good data, without good epidemiologic data, without fully integrated data that allows prediction, we could very well pay attention with lots of resources to things that don't impact long-term health and divert resources from those that do. So I think
can you give an example?
Brilliant question.
Is there an example you can think of where that might have happened? Or, I suppose you're saying we could follow the wrong horse, or we could, as we often do in medicine and healthcare.
Absolutely. I think there's some very interesting data about the dioxin spill, for example, in your home state originally in Pennsylvania and what happened in that environment. And I wonder if, while I believe in absolutely the connection between that environmental crisis and the resulting issues, I wonder about long-term interventions in that community that might have been more impactable over time.
So the opportunity cost of following the wrong event. So that gets back to really good sound data on both the cause and effect and also whether an intervention works or not, because I suppose that's if we come to intervene.
And it's modifiable.
Yeah. Thank you. Jean-Luc.
Well, first I'd like to say that I'm convinced that an environment may create or facilitate some diseases like some cancer, chronic obstructive bronchitis, asthma, allergy, infectious disease, and even genetic disease. And I'm a hematologist, and I have a good example of the role of environment since in sub-Saharan Africa, in patients living there are sometimes a mutation of the hemoglobin molecule, which is supposed to make hemoglobin more resistant to malaria, but is responsible for severe complications, severe disease. So people living here have very frequently this severe disease, which is called sickle cell anemia. But However, I have 3 questions. First, you mentioned the history of places where the patient live, but I think it's also important to know the places the patient visited, because of some diseases which are related, as you said, to vacation, especially infectious diseases. Second, as I said and others said as well, if we are looking at the influence of environment on some diseases at the public health level, there is a risk of misunderstanding the role of geography, because there are other confusing factors, like, of course, lifestyle. And when you showed this slide on the prevalence of diabetes or acute myocardial infections, it's not related to geography, it's related to lifestyle or, again, to socioeconomic environment criteria or determinants. And my third point is that there are 2 different levels, the public health and the individual health. And you alluded to the training. Well, at least in France, and I'm pretty sure in other countries, we learn all these occupational and environmental determinants in the genesis of diseases. We learn that, we know that. So when we are in front of a patient with a given disease, then we look to factors which have been responsible for this disease or for the severity of this disease. So for physician, the problem is the reverse. First the disease, then the environment. And for public health, it might be different. First the environment, second the disease at the collective level. So that were my comments.
Thank you, Jean-Luc. Nora?
I think I'll probably go just explore a little bit on what he said. I think what Dr. Pell said, that geographically areas he have shown us that have certain risks, like ozone or insecticide or whatever. So these are all modifiable risks. It is not something which could stay forever if it's, there is no intervention done. So I don't know if it's just geography or these modifiable risk factors of these people who are here, like having more diabetes or having more ozone. It's not only geography, it is a lot of issues, environmental and things like that. And if we look from the other side, not the personal medical and go look where the person lives, is looking again from the public health point of view, protecting the environment and all modification risks in identified area according to the map which Bill have nicely presented. And I think these areas should be targeted for all these modifiable risks. There is some things which is not modifiable in diseases like genetics, ethnicity, and other things. But I think whatever was presented in Geo, in my opinion, it is modifiable. Probably if it's addressed more in research and interventions through government or agencies or institutions or whatever.
And I suppose the point that Bill's making partly is if the individuals are aware that they are, for example, living in a high ozone level place or a poor air quality place, the political pressure or that information becomes very powerful.
The thing is, the option is for people to move, but what if they can't move?
Well, but I suppose they need, it's not the move, perhaps the information is power in simply them to be able to say, we don't like living in an area like this and let's get some political change or some, I mean, that may sound simplistic, but the information can become powerful.
Yes, I agree.
We hope. Stefan.
So I like this comment that came from the audience, the one which says, so what we are talking about here is just to add more data, which might help to explain public health or individuals' health. And I was really thinking about that comment. To do that, you need more analytics, better analytics. And so maybe we could say this is asking for bringing the Amazon principle to public health. So what does it mean? So that means, number one, just having more data, just having even more granular data is useless. It's useless unless there is there's an algorithm who can extract meaningful, understandable information out of it. What does that have to do with Amazon? It has to do with Amazon. This is exactly what Amazon does. Because they extract all this information, what they know about me, my purchasing history, all the websites that I've visiting before and after, so that they can give me a personalized recommendation. Now imagine that for healthcare, and I think this is exactly what you are dreaming about, which is pick all these pieces of information, your medication history, your treatment history, and enrich it by these environmental factors, by the places you have been living, by socioeconomic factors. And if you bring that all together, that could indeed be a very powerful predictor, helping to give people at least a kind of indication what has been happening or what is happening to your risk score. And I think that might even resolve that chicken and egg problem. Why are people not using their personally controlled health record? Because it is relatively meaningless. It is as meaningless as looking on your rooftop on Google Earth. Why are you looking on the rooftop on Google Earth? So just looking at myself, I did that when we were buying a house. So I was looking at a lot of rooftops in these days. But since then, I haven't looked at the rooftop of this house since 3 years, since we moved into that place. So what does it mean? You look at data, and you probably would look at your personal controlled health record if there is a purpose, if there's something that you can do with it, if there is a process that it triggers. So I was very, very skeptical about these personally controlled health record unless I heard an interesting story. And that story is from a company in the US that manages online physician appointments. It's called ZocDoc, and there are other companies like this in many places in the world. So they started with offering the patients the option to book appointments with their doctors, and they have millions of users, doctors like it, patients like it, everybody's happy. Now they started to offer a health record that you can fill out, similar to what Google launched 4 years ago, which miserably failed, and then Google cancelled this service, Google Health Record, 2 years ago, because nobody used it. However, at ZocDoc, it experiences an amazing uptake. So people really do this painful task in entering their personal health information in this health record. Why are they doing it? Because there is a meaning to it. It's useful to them. They book an appointment, they go and visit a physician, maybe a physician they haven't seen before, and when they arrive, their data travels with them, and the data is already there. So suddenly, this personally controlled health record gets a meaning because it's linked to a process, and this is when it actually starts to get used by patients. And I think the same logic applies to all that data that is around. Somebody needs to develop the capability to give meaning to that data so that the individual, the patient or the physician, can derive the right implications.
Thank you. Before I get Bill to respond to some of that, a call for any questions from the audience. Sophie, Susan, Deirdre, Toby, and anyone else who is tweeting might like to come up to the microphone and explain in more detail what they had to say, but please do ask questions. We've got about another 10 minutes, but I'm just going to ask Bill, while you gather your thoughts in the audience of what you might like to ask, Bill, your response to what you've just heard.
Well, my first response is this is a field that's going to grow, and it needs more landscape architects. And what I mean by that is it's right now filled with people who love blooming flowers. And the blooming flowers are the people who do research projects that are limited in scope. I'm talking about health research projects, both at the population health and the clinical area, where they're limited by sample size, they're limited by budget, and they actually produce some very valuable data that can only be generalized there. So there's not much leverage in this. So what this opportunity is about is actually beginning to move away from that model. In fact, I suspect that most clinical research will not be done. There'll be a portion of it that will not be done in health institutes and medical schools. It'll be done in these huge data laboratories that will bring in all the data from all the medical records, like a ZocDoc, right? And they will actually have these highly skilled mathematicians and epidemiologists that will rent a for better or for worse, an office inside this huge protected space that will begin to do analysis on individual records and begin to look at trends and so forth. In other words, what I'm saying, what has changed is the velocity of the data. In the United States, for example, 17 countries now have the ability that if you see a doctor today, that data it's digitized, that data is available tomorrow. So why has it taken us 2 or 3 years to analyze that data? Well, part of it has been the pipelines, and how we've actually managed the workflow of that. So I would say we're moving from blooming flowers, where we've just got them blooming all over the world and all sorts of research, into these more sculptured, landscape architected gardens, where there's been some thought put into the frameworks that are required by individual physicians, practices, medical schools, and then the research community. And then they will enter this, and it won't be as haphazard as it is now, where we have a great piece of research, but we can't use it outside of, 5 counties in Arizona.
And my only comment in response to that, not that I'm very knowledgeable on the technology, is that I would have thought that part of the joy of this, or part of the sort of the unknown aspect of this, is that the individuals out there are perhaps the best people to sample the bits of information that they think are most relevant. I think what worries some people about the whole Amazon approach is that there's some big brother sense of them selecting what's of value and what's important, whereas potentially if it's actually the public, the people, the individuals are themselves selecting the things that are of value to them, that in itself becomes a more powerful tool for change, as opposed to, do you see what I'm saying, as opposed to some sort of Stalinist kind of oversight thing. Colleen's nodding. She knows what I'm saying.
That's very interesting. It's an interesting flip to the Amazon piece, actually, and that is, what if we had all the data that Amazon had on us and we, in fact, prioritized? You got that one wrong. Even though I did X, it doesn't really mean anything in the broader view.
The thing I really
what I
care
hear you
about
saying is prioritizing those pieces that, in fact, are most important at this point. It's very interesting.
It's like the fact that we get the city, the FTSE 100 thing on the television, and people say, well, what actually, instead of that every day, we should have unemployment figures or, air pollution or whatever the things other people might think are important.
I was going to make one other comment, and it really is, that a lot of this data is yet to be curated, as I would say. It's flowing pretty fast and furious without anybody thinking broadly about its quality and so forth. So there's a whole aspect of this where the people who work in informatics are going to have to get their hands dirty in actually validating some of this data that is going to find its way into electronic health records. Are you familiar with Patients Like Me, that website? And it's still growing, and I heard the other week that they're actually going to be using some of that database for launching some clinical trials. So what you have going on here is relatively consumer-focused efforts beginning to change the way clinical research will be done. And the data that Patients Like Me has, like on ALS patients, is like 10 times the volume that NIH has on the same subject, and more than the FDA has on the subject. And suddenly now there's an imbalance in the research community of who's got most of the data and how complete is it. The Patients Like Me has questions in it like, how does prayer affect your outcome? You will never find that in an NIH study.
We had one in the BMJ, actually. We published a study, and I think the result was positive, but none of us could work out why. None of us. I'm sure many could. Any more questions from the floor at all? Can I encourage you to question what you've heard, challenge it, offer alternative ways in which this data could be used? No one's going to come forward. I think with that, on that note, I will then say thank you very much indeed to Bill Davenhall for a fascinating presentation with all sorts of potential to take forward, and to our excellent panel for your comments. Many thanks indeed, and thank you to all for coming. Thank you.
Thank you.